I feel human beings are the most unthankful species on this planet, accounting for all the carbon footprint that we leave behind. I feel we should be thankful for everything: the water we drink, the food we eat, and the air we breathe. Breathing is so subconscious, spontaneous, and is so trivial to even notice. It is only an asthmatic individual who can feel that impending sense of doom arising out of air hunger. That is why it becomes important for us to learn everything about bronchial asthma. Bronchial asthma has got a higher prevalence, especially in developed countries. The so-called developed countries like Australia, US, Canada have got an higher incidence of asthma. And lately, there is an increasing prevalence and incidence of asthma lately. As you can see here in this diagram, there is an increased incidence of more than 10. That is percentage of population. And in India, it is somewhere between 2.5 to 5. It has been estimated that around 300 million people are affected with asthma, and even 100 more million people will be affected by year 2025. So how do you define asthma? There is no agreed universal definition of asthma. It is thought that it is a chronic airway inflammation with an increased airway hyperresponsiveness. So this is a prototype patient that I'll put in front of you. It is an individual who has a strong family history of atopy, or who has atopy himself, or who has a family history of unaffected member with asthma. So this individual gets a first attack of asthma anywhere in his childhood. So this individual receives repeated form of nebulization and is a candidate for asthma. In an adulthood, that individual can spontaneously go into remission for asthma or can develop a permanent disease. Peak incidence of asthma is seen at an age of 3 years. So generally, these individuals will have the first attack of asthma during their childhood. These individuals will need some form of treatment for years together. Those individuals can go into remission. Or few individuals who have got a genetic potential, those individuals can have the first attack of asthma even in adulthood, as far as even in their 40s or 50s. Generally, these individuals who have got their first attack later in the life or in the adulthood will usually develop permanent symptoms. Usually in the childhood, males are affected twice commonly as females. But when they grow out in the adulthood, sex ratios are normalized. Now, this asthma is arising as a result of abnormality in the conduction airways. Here, there is an expiratory narrowing. There is an increased airway hyperresponsiveness, as a result of which there is an increased expiratory constriction. There is a bronchoconstriction which is reversible. So that is why I told you this is an important disease which you can reverse. There is a reversible airflow which you can reverse by giving medications such as steroids and beta agonists. So to understand the pathophysiology of asthma, we need to understand 3 factors, namely the endogenous risk factors which are responsible for the development of asthma, environmental exposure, certain agents, be it indoor or outdoor pollution, be it certain infectious agents, or be it any exposure to drugs. Those individuals will have some form of chronic airway inflammation. Now, when these individuals have a chronic airway inflammation, when exposed to certain triggers, develop an acute attack of asthma. So to understand, there are 3 risk factors: endogenous risk factors, there are certain environmental risk factors which lead to a chronic airway inflammation. When in the presence of trigger, it can lead to acute attack of asthma. So what are these endogenous factors? First to talk about is atopy. Atopy means an individual might have a familial or a genetic history of atopy, or might be suffering some form of atopy himself or herself. So that individual might be suffering from allergic rhinitis or atopic dermatitis, which we call it as eczema. Here, there is an increased or hyper-responsiveness by producing increased levels of immunoglobulin E, that is IgE, in response to allergic rhinitis or eczema. So that individual is at a high risk of developing asthma. So it has been found that up to 40 to 50% of individuals suffering from asthma will have some form of atopy. Next comes genetic predisposition. Now it has been found that, especially in twins, if one twin is affected with asthma, the other twin will some or the other phase of his life will develop asthma. So that supports strongly to the thought that there might be some genetic factors which are responsible for development of asthma. So certain genes have been found out. Two of them are ADAM33 and DPP10. So presence of these genes have been associated with an occurrence of asthma. Other is the gender. As I told you, there is an increased occurrence of asthma in males in the childhood, and finally it is normalized in the adulthood. There is an airway hyperresponsiveness, which is an endogenous factor for development of asthma. BMI more than 30 is thought to be a risk factor for asthma. And ethnicity, especially a North American or a European ethnicity, is at a high risk of developing asthma. So that was about endogenous factors. Now moving ahead to environmental factors which would lead to or which would contribute in developing asthma are indoor or outdoor allergens, occupational exposures, passive smoking, air pollution, recurrent upper respiratory infection, or some changes in diet, consumption of specific nuts, dampness, or exposure to mold. They can all contribute to the formation of asthma. Now coming to triggers. What are triggers? So this individual has got a endogenous factor exposed to certain environmental factors and has now got certain triggers which will trigger an acute attack of asthma. They can be certain allergens, upper respiratory tract infections, or even a condition called as exercise-induced asthma, typically seen after the exercise has been ended and which lasts up to 30 minutes. Even hyperventilation can precipitate asthma, and certain drugs like beta blockers, aspirin, are also known to precipitate an acute attack of asthma. Even an emotional stress or a physical stress or irritants such as household sprays and paint fumes can also precipitate an attack of asthma. Now, what is the pathophysiology of asthma? Now, we have read an individual has got a genetic potential or has got an atopy, some form, or has got a strong family history. That individual is exposed to certain environmental factors. Now, this exposure will lead to a airway remodeling. It will lead to airway hyperresponsiveness. How does it happen? We will try to understand based on this image. Here, there is an exposure of allergen to the dendritic cell and the mast cell. Now, there is an abnormal activation of mast cell. What it will cause is, it will increase the number of eosinophils within the bronchial mucosa. So, increased recruitment of eosinophils in the bronchial mucosa causes an increased synthesis of chemical mediators of inflammation as well, be it cytokines, chemokines, and growth factors. Now, importantly, cytokines and chemokines will cause inflammation. They will cause vasodilatation, which will be responsible for a plasma leak. It will cause an increased secretion of mucus and growth factors, which will cause an hyperplasia or hypertrophy of smooth muscles of the airway. So the important changes I will revise. It will cause a vasodilatation, which is responsible for a plasma leak. It will increase the mucus secretion within the bronchial smooth muscles and the epithelium, which is responsible for formation of a mucus plug. The narrow airways, which are already narrowed by the hyperplasia or hypertrophy of the smooth muscles, are further narrowed by a formation of a mucus plug. This is all occurring because of an abnormal infiltration of the bronchial mucosa with the eosinophils or type 2 helper T cells. So these are occurring as a result of chemical mediators of inflammation, namely chemokines, cytokines, and growth factors. So this is a histopathological image for you to understand what is happening at the bronchial level. Here you can see there is a hyperplasia and hypertrophy of the bronchial smooth muscles. So the bronchial lumen that has to be normally large enough to conduct the airway without any obstruction is further narrowing. So you can see here, these are the normal parenchymal attachments with the presence of thickened airway smooth muscle and in inflammatory infiltrate that you can see here in the submucosal layer. and a presence of mucus plug within the lumen, which further narrows the bronchial lumen. So this is a typical histopath image of an individual with bronchial asthma. So to quickly recap the pathophysiology. So what happens in asthma? It is the individual who has got a genetic potential or an atopy when exposed to environmental factors, develops airway remodeling or airway hyperresponsiveness. So this individual who has got a genetic potential gets exposed to certain environmental factors, and there starts a process of chronic airway inflammation. Now this chronic airway inflammation leads to two things. It leads to airway hyperresponsiveness to any triggers, and it can lead to airway remodeling. What airway remodeling is occurring? There is a narrowing of bronchial lumen. There is a hyperplasia and hypertrophy of the smooth muscles. There is increase in plasma leak. There is a formation of mucus plug. All these are the airway remodeling process. Second, here what is happening is there is an increased responsiveness, increased airway hyperresponsiveness. So when this individual is subjected to any trigger, that individual will end up in an acute attack of asthma. So a normal bronchiole should look like this with a normal lumen. So an individual who is suffering from bronchial asthma will have a lumen like this. Because of the hypertrophy and the hyperplasia of the muscles, and because of a presence of a mucus plug. So here you can see the difference. This is a bronchi with a normal lumen. Look at the caliber of the lumen of a normal individual. Look at the caliber of a individual who is suffering from asthma. This is the reason why there is an expiratory obstruction, why the individual will have the symptoms of asthma, be it wheeze, be it cough, dyspnea, or chest tightness. So coming to the clinical features of asthma, as I told you, these individuals will typically have wheeze, cough, chest tightness, or dyspnea, all arising as a result of expiratory narrowing of the airways. Now these individuals, some of them have prodromal symptoms. These prodromal symptoms can be itching anywhere around the nose. There can be lacrimation or even an impending sense of doom. There is wheezing, which is even audible without a stethoscope in some individuals. There is cough, chest tightness, dyspnea. Further, chronic asthma will lead to an air trapping because of the narrowing of the airways, which can lead to VQ mismatch, and rarely it can lead to an important cause of secondary pneumothorax. So what are the investigation in an individual with asthma? Asthma diagnosis is basically based on the history and the clinical presentation. Although few investigation has to be undertaken to rule out any other associated diseases or complications. CBC, you would want to look for any presence of infections, any secondary infections by presence of any leukocytosis or presence of any viral infections, which can be reflected as thrombocytopenia, or presence of any leukopenia. Typically, an individual with atopy will have an increased eosinophil count. Similarly, an individual with atopy will have a higher IgE count, immunoglobulin E count. Next is a chest X-ray. An individual who is suffering from asthma will have an absolutely normal chest X-ray, or they might have a hyperinflammation of lungs. So chest X-ray has to be done in a first case of asthma, because you want to rule out other causes. You want to rule out other presence of any pneumonia or an incidental presence of allergic bronchopulmonary aspergillosis. Must be ruled out in an individual with asthma. Skin prick test, which are typically done to rule out the presence of atopy. And finally, spirometry will give away the diagnosis of obstructive lung disease, namely asthma. So let's go ahead and look at what are the spirometry findings. So spirometry will give you this following report. Total lung capacity is typically preserved, which is 100%. The values reflect the percentage of expected values in a normal individual. Residual volume is typically increased 120% of the normal. Here, why is it increased? Because of the bronchoconstriction, there is more of air trapping. The amount of air that is left behind at the end of the expiration, that is residual volume, is high. Forced vital capacity is up to 90%, which is slightly reduced. And FEV1, that is forced expiratory volume in 1 second, is severely reduced as low as up to 35%. So what happens here is, in this graph you can clearly see, here the volume of the lung during expiration is plotted against seconds. So this is the volume of the lung and this is the time frame. Here in a normal individual, which is shown in a blue color graph, here you can see the FEV1 is 3.5 liter and FVC is 4.0 liter. When you compare that graph to an individual who is suffering from asthma, you can clearly see this individual has a higher drop of forced expiratory volume in 1 second, that is FEV1. But there is a reduction of FVC also. But the amount of reduction of FVC is less. There is a lesser reduction of FVC. As a result of which, when you take a ratio of FEV1 by FVC, there is a greater fall. That is, these values are usually less than the 70% of the predicted, which gives you a diagnosis of asthma or obstructive lung disease arising out of asthma. Now, getting this report is not just enough. We have to demonstrate that this bronchoconstriction or this obstructive pathology that we have got on a spirometry is reversible. Only then you can make a diagnosis of asthma. Apart from FEV1, you can find out resistance of airway, which is typically elevated. A normal resistance is 1, here it is 2.5. So what is reversibility I'm talking about? Here FEV1 is 35% of predicted. Now, after giving a short-acting beta agonist, especially an albuterol of 400 microgram, we need to check for reversibility. Now, reversibility, a successful reversibility is defined as an increase by 12% of FEV1 or a more than 200 ml increase in FEV1 after giving an albuterol of 400 microgram 15 minutes post nebulization. So there has to be a reversal of FEV1 by at least an increase in 12% or an increase of volume by 200 ml 15 minutes after giving a short-acting beta agonist, namely albuterol. So this reversibility is classical of asthma. So this obstructive physiology is not because of emphysema or COPD. This is typically because of asthma. Because if this kind of obstructive physiology is arising out of asthma, arising out of emphysema, that is not reversible. In this case of asthma, it is well reversible by using a short-acting beta-2 agonist. So once you have diagnosed, GINA says that you need to categorize that individual. Whether that individual comes in one of the 3 categories. The 3 categories are: the individual is a controlled case of asthma, or an individual is partly controlled or uncontrolled. Now, GINA stands for Global Initiative for Asthma. Now, they have formed out 3 categories. As I told you, controlled, partly controlled and uncontrolled, depending upon the presence of the symptoms. So, if the daytime symptoms are less than 2 per week, with the absence of all these symptoms, either a nocturnal symptom or need of a reliever or a rescue treatment with a normal lung function and no exacerbation, that individual is called as a controlled case of asthma. If there is an increased daytime symptoms of more than 2 per week, or presence of limitation of any form of activity, or presence of nocturnal symptoms or awakenings, and if the individual is requiring a rescue or a reliever treatment more than 2 per week, presence of any of one of this feature for more than 1 week can tell you that individual is in partly controlled category. If there are more than 3 features of partly controlled, then that individual goes to a poorly controlled or uncontrolled asthma. So we need to categorize depending upon the GINA guidelines whether that individual falls in the controlled, partly controlled or uncontrolled category. Now, how do you manage this individual? After forming the category, after deciding that individual falls in which category, we have to adopt the strategy accordingly. There is a stepwise approach for any individual who is suffering from asthma. The first step is occasional use of inhaled short-acting beta-2 agonist, which forms the base for any type of asthma. Be it a mild intermittent asthma or be it a severe uncontrolled asthma, short-acting intermittent use of beta-2 agonist forms the basic treatment for all of the forms of asthma. Here, they are typically used to prevent the recurrences or prevent the acute attacks of asthma. So that individual who is suffering from a mild intermittent asthma can simply be put on this inhaled short-acting beta-2 agonist and sent home. If that individual is suffering from recurrent attacks, then that individual is a candidate for regular preventive therapy, which is usually an addition of inhaled corticosteroids. If that individual is again not responding, then you put an add-on drug. So add-on drug is usually a long-acting beta-2 agonist. So the first baseline was a short-acting beta-2 agonist. Here, we add on a therapy with inhaled corticosteroids with a long-acting beta-2 agonist. So usually, the inhaler comes with a combination of inhaled corticosteroids plus a long-acting beta-2 agonist, which is namely salmeterol plus formoterol. If even after this, that individual is not responding, then you go to the fourth step. The fourth step is either addition of a newer drug or increasing the dose of inhaled corticosteroid. The maximum dose of inhaled corticosteroids, be it a budesonide, can be used as high as up to 2000 micrograms. Or you can add another drug called as LTRA, that is leukotriene receptor antagonist, namely montelukast, can be added and tried in fourth step. Even after this, if the individual is not responding, you move ahead to the final step where there is a continuous or frequent use of oral steroids. Now, once you begin steroids, if the individual has received steroids for more than 3 months, that individual has to be monitored for adverse effects of steroid long use. That might be osteoporosis, hypertension, glucose intolerance, Cushingoid features, etc. So what are the drugs that we are able to use in asthma are, as I told you, short-acting beta-2 agonists such as salbutamol or terbutaline, long-acting beta-2 agonists called as LABA. They can be salmeterol, formoterol, inhaled corticosteroids. They can be either beclomethasone, budesonide, fluticasone or cyclisonide. And one class of drug that I told you, leukotriene receptor antagonist, montelukast, whose dose is 10 milligram daily, can also be used. And in step 5, when the individual is not responding or a severe form of uncontrolled asthma, that individual can be started with an oral prednisolone of dose 30 to 60 milligram per day. And if none of this, the individual is responding to none of these 3 forms of treatment or has been suffering from a steroid side effect, that individual can be treated with other types of immunosuppression or newer drugs. Other type of immunosuppression can be methotrexate or cyclosporin or monoclonal antibody against immunoglobulin E, especially useful in individuals who are suffering from atopy. A use of omalizumab, mepolizumab, or even thermoplasty has been recently found to be beneficial in individuals who are suffering from airway hyperresponsiveness. So this is a stepwise approach of an individual who is suffering from different forms of asthma. Below mentioned are the categories of asthma. It can be a mild intermittent asthma, mild persistent asthma, moderate persistent, or even severe or very severe persistent asthma. So this is a stepwise approach. This is the first step that I told you, which forms the base for all the treatment. That is the use of short-acting beta-2 agonist as required for the symptom relief. That individual is given on an SOS basis. That individual can use it 2 times a day or 3 times a day, even a maximum of 4 times a day. Next comes an addition of a continuous reliever therapy. That is an use of inhaled corticosteroid at a lower dose, which is a step 2. Step 3 comes, if this individual is not responding to inhaled corticosteroids, then you need to do a step 3, that is addition of another drug, that is a long-acting beta-2 agonist. The step 4 is if the individual is not responding even to this, then you put an add-on drug or you increase the dose of inhaled corticosteroids. Here you are increasing the dose of inhaled corticosteroids or either adding a leukotriene receptor antagonist. Even if at this point the individual is not responding, which brings us to the stage 5, that is the use of oral corticosteroids. So this is a stepwise approach of an individual suffering from different forms of asthma. So one dreaded complication, as I told you, all we are scared of in an individual who is suffering from an asthma is an acute attack of asthma, because it is a very much preventable disease. It is an easily treatable disease, but yet ignored and can be an important cause of mortality So an individual who's coming to with an attack of acute asthma, the first treatment of choice is oxygen. You titrate the oxygen depending upon the target saturation, which has to be kept above 92%. These individuals must be treated with high doses of inhaled bronchodilators, specifically a short-acting beta-2 agonist with a dose of 5 to 10 mg. Especially if you don't have an hospital access or a reach, that individual who has simply having an salbutamol, rotahaler, or even an inhaler, that individual can do a repeated inhalation once in every 20 minutes for 6 inhalations. That is equivalent to the nebulization that individual will be receiving at a hospital setting. This can be given with a combination of ipratropium bromide, which antagonizes the bronchoconstriction by anticholinergic mechanism. Then you can use systemic corticosteroids, namely IV hydrocortisone. Aminophylline has a good role in controlling this acute attack of asthma, which is not responding to salbutamol nebulization, which is given at a dose of 5 mg per kg, a loading dose followed by a maintenance or infusion dose of 1 mg per kg per hour. And magnesium sulfate, either in a nebulization form or an intravenous form, can also be given, whose dose is 1.2 to 2 gram over 20 minutes. And in individuals who have ended up in a respiratory failure or who have signs of impending respiratory failure, must go for assisted ventilation. So to summarize, it is a syndrome characterized by airflow obstruction that varies markedly, both spontaneously and with treatment. So it is a chronic airway inflammation with an increased airway hyperresponsiveness, which is reversible. Asthma can present at any age with a peak of 3 years. As I told you, especially the asthma which presents in the childhood, it may grow out. That individual may go on to remission for lifelong without any symptoms. But an asthma with its first attack in the adulthood will usually be symptomatic for lifelong. Risk factors include an endogenous or an environmental risk factor, as we all studied about. When subjected to certain triggers, may end up in acute attack of asthma. These triggers are an viral URI, especially a respiratory syncytial virus or even coronavirus, allergens, stress, drugs, or even exercise, which leads to exercise-induced asthma, especially an individual who is working out in a cold and dry environment, or exposure to certain paint fumes can also precipitate an attack of asthma. Chronic inflammation is characterized by abnormal recruitment of eosinophils, mucus hypersecretion, vasodilation, plasma leak, and epithelial shedding, which forms the basic pathophysiology of an individual with asthma. Usually, in an asthma, this bronchial wall have got a increased infiltrate of eosinophils. But there is one variety where eosinophils are not predominating. It is the neutrophils that are predominating. So that type of asthma is also called as paucigranulocyte asthma. Inflammatory healing leads to airway remodeling and abnormal airway hyperresponsiveness that we all spoke about. Clinical features include wheezing, cough, or dyspnea. Sometimes this wheezing or cough is usually seen in the early morning, but sometimes it can disturb sleep, and that kind of asthma can also be called as a nocturnal asthma. So to diagnose an asthma, spirometry findings are a low FEV1, a lower FEV1 by FVC ratio. Because here the magnitude of fall of FVC is not that high when compared to a fall in FEV1. So the expected FEV1 is less than 70%. The ratio of FEV1 by FVC is less than 70%. And there is a demonstration of reversibility. By giving a nebulization of short-acting beta-2 agonist, namely albuterol, after infusion of 400 micrograms of albuterol, you remeasure the FEV1 values after 15 minutes. An increase in 12% or an increase in more than 200 ml of FEV1 is expected in case of asthma. Global Initiative of Asthma has classified levels of asthma into controlled, partly controlled, and uncontrolled asthma. Management of chronic asthma includes avoidance of triggers, all the number of triggers that we studied, and stepwise approach, a 5-step approach that we learned of. Management of acute asthma includes supplementing oxygen, maintaining a saturation of more than 92%, nebulization with a short-acting beta-2 agonist, namely salbutamol, in combination of ipratropium bromide, using an aminophylline infusion by a loading dose of 5 mg per kg followed by an 1 mg per kg per hour of infusion, or use of systemic corticosteroids, or even use of magnesium sulfate in form of nebulization or IV. So this brings us to the end of a learning on bronchial asthma.